And now we move on to the presentation of the first guideline of today. Maria Luisa Zedde, who is a neurologist working at the Stroke Center of the Reggio Emilia in Italy, and who was one of the co-chairs of this guideline and has a main expertise in rare neurovascular diseases, will now present the guideline on primary angiitis of the central nervous system. Maria Luisa, we are all looking forward to hearing about your and your group's work.
Thank you, Silke, for the presentation. These are my disclosures, and it was a pleasure to coordinate this fantastic multidisciplinary group, including neurologists, vascular neurologists, neuroradiologists, rheumatologists, pathologist, and one methodologist. So the first and last authors of the paper are neuroradiologists and neurologists. So we are, I think, well represented as a neurovascular society. Why is needed a guideline on PACNS. PACNS is a subtype of vasculitis with isolated involvement of the central nervous system. The diagnosis, as Nils Kalding already said, may be challenging, and it may be challenging at three overlapping levels: at a neuropathological level, at a neuroimaging level, and clinical levels. The levels we address in clinical practice are mainly neuroimaging clinical level. It's a rare disease, and the median age of diagnosis is 50 years. So we have two sets of diagnostic criteria provided by time. The first set is represented by the criteria published by Calabrese and Malek in 1988. And the second set is provided by Birman and Ellman in 2009. Birman and Ellman introduced definite and probable categories: definite PACNS if histopathological confirmation, and probable if a high probability DSA associated with MRI and CSF profile consistent with PACNS. But it is important to note that if the criteria proposed by Calabrese and Malek were assessed in 6 subjects, the criteria proposed by Birman and Ellman was never assessed in any patient before proposing. So they represent the vision and the personal opinion of the authors. These criteria have several limitations. No strong data supporting the current diagnostic criteria exist. So angiography-proven PACNS and biopsy-proven PACNS are two different subtypes of the disease. Angiography-proven PACNS refer to large and medium vessel involvement, and small vessel involvement, SVPACNS, is mainly diagnosed by biopsy. So medium vessel category is a neglected category, not only in vasculitis. Moreover, new technologies, new differential diagnosis are increasing by years, so we have to consider them. So the challenges in diagnosis and management are also this limitation. So the definite diagnosis require histopathological confirmation. Risk-benefit of biopsy are to be adequately considered, because biopsy-proven vasculitis is not vasculitis in general, but only small vessel vasculitis, and in some cases medium and small vessel vasculitis. So we have non-invasive techniques and minimally invasive techniques, but we have to prove they are efficient and safe for diagnosis. And given the lack of specificity of both the presenting symptoms, non-invasive investigation, the confirmation of the diagnosis is a challenge. It remains a challenge. And even when the diagnosis is somewhat confirmed, the evidence base for therapeutical intervention is really poor. Finally, many areas regarding diagnosis and management of PACNS patient lack of standardized clinical evidence. So the main purpose of these guidelines is to provide answers to predefined PICOs, and to give a standardized base to address clinically and diagnostically PACNS patients in order to improve the management of this patient in a neurovascular field. So we use the ESO standard operating procedure as a template to build this guideline. The definition of the P for population is probable and definite PACNS according to the Birman and Hellman criteria when possible. We formulated 17 main PICO questions focusing on diagnosis, differential diagnosis of large vessel and small vessel PACNS, and the efficacy of several treatment regimens. The diagnostic PICOs were divided according to the techniques suggested by the criteria. So PICO about CSF, PICO about neuroimaging findings, and PICO about histopathological changes. So in the therapeutic PICOs were divided into disease-specific treatment of the acute phase, maintenance therapy, so induction and maintenance therapy, secondary prevention, a neglected issue, and also acute stroke treatment in patients with PACNS. Unfortunately, we don't have any randomized controlled trial, so there are only small retrospective case series covering a wide range of years. We use the definition of high probability angiographic pattern provided by Duna and Calabrese in 1995. It is written in the blue box, and we use a modern definition of relapse and remission according to the recent literature from neuroimaging based management of patients with PACNS. The definition of induction and maintenance therapy was the acute phase and the therapeutic intervention after induction therapy respectively, but unfortunately the timing of induction and maintenance therapy are poorly defined in the literature, are highly variable. So the module working group agreed to not consider the timing as a focus of our PICOs. So I listed some example of our PICO. So PICO 1 addressed CSF analysis. So in adults with suspected PACNS, the CSF analysis for pleocytosis and hyperproteinuria versus no CSF analysis improved diagnostic accuracy. This is our question. So unfortunately, we cannot produce any real recommendation because there is a persistent uncertainty over the utility of CSF examination for pleocytosis and hyperproteinuria as a diagnostic tool. This is due to the lack of specific comparative studies and to the heterogeneity of data. We formulated an expert consensus statement indicating CSF examination in patients with a suspicion of PACNS, mainly in order to perform a differential diagnosis versus other disease, for example, post-infectious vasculitis and non-vasculitis. CSF analysis should not be limited to determination of cell count and protein concentration, and normal CSF analysis cannot exclude the PACNS diagnosis. So this is a table of the study we considered for answering this PICO. Please note the number of boxes with NR or NA data. So several data were not retrievable, were not assessed in the studies. This is a limitation for all PICOs and all outcomes in all examined studies. So we retrieved 17 papers on 763 PACNS patients, but 77% of patients underwent lumbar puncture. CSF data were provided in 86% of these patients. The main problem is that different thresholds for hyperproteinuria were used. So we have some study with a CSF protein threshold over 45 milligram per deciliter, or over 50, or over 80. Another problem is that the normal threshold for CSF protein, for example, is not a fixed threshold, because a recent study evaluating total CSF protein level in a community-based population stated that the mean CSF protein was higher than expected, and that the threshold of normality is variable by decades of age. PICO2 addressed the neuroimaging issues. So in adults with suspected PACNS, does assessing for predefined patterns of parenchymal abnormalities on MRI versus not assessing these patterns increase the diagnostic accuracy. Once again, there's uncertainty regarding this issue, and we don't have information about the clinical utility of identifying predefined pattern of parenchymal damage on MRI to improve the diagnostic accuracy of PACNS and to differentiate small vessel from large vessel PACNS. Several data are underreported and not specifically comparable among the several studies. Our expert consensus statement in this case was that in adults with definite or probable PACNS, neuroimaging findings should be reported in a standardized way according to the already described pattern of parenchymal involvement and contrast enhancement on MRI. This is relevant, this is of paramount importance to collect data prospectively. Given the potential selection bias in patient undergoing biopsy, we suggest to be cautious in attributing some patterns, for example, tumefacitic pattern to small vessel or large vessel PACNS. As you can see, we search for acute ICH or SAH pattern, tumefacitic pattern, multiple or single acute subacute ischemic lesion, small vessel disease pattern according to the STRIVE criteria, or parenchymal contrast enhancement, and finally spinal cord involvement. But the available data were really heterogeneous and underreported. This largely reflect the retrospective design of studies. No real neuroradiologist involvement or vascular neurologist involvement is present in several of these studies. And no neuroimaging pattern was reported to be suggestive or a single subtype of PACNS. Continue with neuroimaging PICOs, PICO 4, in adult with suspected PACNS, CTA or MRA with high probability angiographic pattern versus DSA with high probability angiographic pattern. Improved diagnosis, this is our first recommendation because in this category of patients, we don't recommend using MRA routinely in place of DSA. Unfortunately, no recommendation can be drawn for CTA, but the clinical utility of CTA already, it has not been formally compared to MRA DSA in PACNS patient, could be relevant. So we suggest that CTA could be comparable to MRA if a multi-slice technique is employed. DSA has a higher sensitivity and specificity in detection of medium-sized vessel involvement in comparison of both MRA and CTA. It is less invasive than brain biopsy, so we suggest that DSA is considered in patients with clinical suspicion of PACNS and negative MRA and CTA. So only 5 papers respected our criteria, and they provided data on 186 patients. 109 patients underwent DSA and 122 underwent CTA, but only one study directly compared MRA versus DSA in 31 patients, but they don't compare the high probability angiographic pattern, but they made a per segment analysis and the detection of vessel stenosis in predefined segment of large intracranial arteries, not medium intracranial arteries, rather than the detection of the high probability angiographic pattern is a limitation, is a relevant limitation. For example, if an MRA is able to image severe stenosis of the carotid terminus, as in this case, and it is better imaged in DSA, it is really unlikely that MRA can image this involvement of medium vessels. And it is also difficult to think that also last generation scanner can image by MRA this involvement of tubular stenosis of medium vessel in another patient. The same is valid for the three-dimensional reconstructed angiography for example, in branches of anterior cerebral arteries, as in this picture, and dilation is a part of the criteria, not only stenosis, and it is better imaged by DSA than MRA and CTA, and the same is for beading, and a similar conclusion can be drawn for occlusion. So this occlusion with a collateral bridging in ACA branch cannot be explored by other technique than DSA. So this is a relevant limitation for non-invasive technique. So I continuing with neuroimaging in adult with probable large vessel PACNS, PICO 6. Thus performing high-resolution vessel wall imaging MRI versus performing DSA increased diagnostic accuracy. Unfortunately, there is insufficient data on high-resolution vessel wall imaging to determine whether this technique improves the diagnostic accuracy of PACNS when used with DSA. So it's a promising tool, but this technique has not yet validated. So we suggest that it should be investigated and validated in prospective multicenter trial, and that the diagnosis of PACNS cannot be formulated only by the finding of high-resolution vessel wall imaging. So only 3 papers respected our criteria. They provided data on 73 patients. The first bias is that is a selection bias, because in the studies patients were selected because they performed high-resolution vessel wall imaging, and no study provided adequate information regarding the change in diagnostic accuracy provided by this technique when compared with ESA. Leptomeningeal enhancement was another neuroimaging findings when we focused our attention in PICO 9, and our question is that if in adults with definite PACNS, the presence of MRI leptomeningeal enhancement versus positive biopsy finding change diagnostic accuracy. And once again, there are no data to provide a recommendation, and there is persistent uncertainty regarding the effect on diagnostic accuracy of the presence of leptomeningeal enhancement. So there is a big problem, because information regarding contrast administration is not provided in all studies, and because in patients with leptomeningeal enhancement and positive biopsy, the information regarding the location of the sample is often lacking, so precluding any precise analysis of the link between leptomeningeal enhancement and biopsy results. We have some PICOs about treatment, for example, acute phase treatment, induction treatment, PICO 12 in adult with probable and definite PACNS, thus using glucocorticoids plus any further immunosuppressive drug versus glucocorticoids alone improve outcome. Not surprisingly, we have a persistent uncertainty regarding the clinical benefit associated with the use of immunosuppressive drugs in addition to glucocorticoids. There are several limitations. We elaborated an expert consensus statement considering also the potential severity of PACNS, the relapsing course of the disease, and glucocorticoid-related toxicity. So we suggest the consideration of adding an immunosuppressant to glucocorticoid therapy alone. But if you look to the data, you can see that the predefined outcome were largely underreported and underrepresented, and it is a great limitation to formulate a recommendation. And we have data from 4 papers, and many patients had combined therapy with glucocorticoids and immunosuppressant, but the timing and the type of therapy is really different paper by paper, and that there is also a possible selection bias regarding mild disease phenotypes treated with glucocorticoids alone versus more aggressive presentation treated with combination treatment. Shifting for a moment to the secondary prevention, this is the PICO regarding antiplatelets. Antiplatelets mean aspirin in this case because we have no data about other antiplatelets. So also in this case, we cannot provide a recommendation, but we suggest aspirin may have a beneficial effect in PACNS. This is based only on one study. This benefit may be due to a combined antithrombotic anti-inflammatory effect, and it's possible complementary action with glucocorticoid, but there is a wide room for a clinical trial for gaining real evidence. It's interesting that there was no significant difference in the prevalence of intracranial hemorrhage, although 7.5% versus 13% in non-taking aspirin and versus taking aspirin cannot be regarded as safe absolutely. The question about long-term immunosuppression, so maintenance therapy, improving the outcome is a relevant question, and we have some surprising result. There is a persistent uncertainty regarding the use of long-term immunosuppression, but this uncertainty is due to the fact that only 2 studies contributed large series, but only 2 to this data, and that fundamentally the most patients were treated by glucocorticoids alone. So the number of patients treated by glucocorticoids alone is higher than the number of patients treated by maintenance therapy. In the maintenance therapy cohort, the most used drug is azathioprine. So the available data don't allow an evidence-based recommendation regarding the duration of the maintenance treatment, type and duration of maintenance treatment. So in the cohort and the investigation, the median duration of maintenance treatment was 24 months and 17 months respectively. So this is my conclusion. So this is the first international multidisciplinary guideline on PACNS. The current diagnostic criteria have several limitations, and this issue was addressed in detail. So the quality of the evidence is globally very low. There is no dedicated neurovascular approach in analyzing the data. Neuroimaging information are underreported, and it makes the data not really comparable. New techniques, for example, high resolution vessel imaging, are promising, but they need to be validated and standardized. Only DSA remain the gold standard for large and medium-sized vessel imaging. Thank you.
Thank you so much, Maria Luisa, and all your team for this great work in a very challenging topic. Congratulations once again.